I want to thank Dr. McCarty for inviting me here to talk today. It's a great pleasure. I wish I was out there in person, but hopefully maybe next year. So today the topic of my talk is really physical therapy for the painful shoulder. I have some disclosures which Dr. McCarty helped me with, so let's get on to the talk. Luckily, the shoulder is not complex at all, and obviously I'm kidding. When you look at the anatomy of the shoulder, it's oftentimes very difficult to figure out exactly why the shoulder is painful. And then you put in the anatomy of the upper quarter, the angles that we have to deal with, and it makes it much more complex. So really how we start is when we're approached by a patient with shoulder pain is really a careful examination that was given to us by Dr. Meyer, really focusing on what are the things that can bring us to a better outcome for this patient. And so for me, if we focus on the basic science, it always helps me to sort of plan my treatment by focusing on first, what structures really are able to, or are most painful in the shoulder based on their sensory, sympathetic, and substance P fibers. Then thinking about the complex movements, the functional independence with ADLs and our daily demands, and some of the biopsychosocial factors that we have to deal with. If you look at the pathology, which we're describing today, really some pathologies are associated with higher levels of pain and some with lower levels of pain as a common symptom. And then there are pathologies that really span the spectrum of how much pain the patient usually presents with, like osteoarthritis, depending on the stage. But whenever we magnify the load or increase the load to that shoulder, regardless of pathology, it normally will increase the symptoms of increased pain and decreased function. So we can take some of the information that the patient gives us, and we know that certain patients typically present with certain pathologies, but we still need to go through our process, which is clarifying that the pain that the patient is feeling in the shoulder is from a musculoskeletal, not medical cause, and then it's somehow associated with movement. So the willingness to move is often a key factor in our examination. We're looking for global and local patterns of pain and local patterns of impairment, as well as overall joint function. And these really help us to clarify the profile of the patient and the expectations we can have with treatments that we deliver. So our focus really needs to be on not only the pain, but the impairments the patient presents with. And I think this is a really good paradigm that's helped me approach people with generalized shoulder pain, the impact of the level of irritability on the patient. So this was presented in a 2013 JOSPT article by Kelly and colleagues, which was the first CPG put out by the American Physical Therapy Association. It really characterizes what level of irritability the patient approaches us with or appears in our clinic with, and talks about their level of pain, what is associated with that level of pain. And we can, of course, see that their impairments are greater with the highest level of irritability. But not only do we want to think about the level of irritability when the patient appears for their first evaluation, but really how they progress through this process. And we want to match the treatment then to the level of irritability. This algorithm is also included in that 2013 article and really talks about the highest level of irritability is best matched with more passive treatments that can be progressed to active treatments within acceptable symptoms. And as we progress, we can do more active treatments and approach more of the specific deficits that people have. And in the areas of low irritability, we can really be aggressive in having the person do some of their own self-care stretching exercises and progress to neuromuscular re-education. But not all people present with a clear-cut level of irritability. There's some people that just don't fit this pattern of high, moderate to low or low level of irritability. There are people that have really good full function for ADLs and basic activities, but then present with significant impairment and high levels of pain associated with higher levels of activity. So for instance, when a worker approaches you with a primary complaint of really significant limitations at work, they may have full function at home and deny any problems in their daily life. So this is the story of a 46-year-old right-hand dominant male who presented 6 months after he had an acute episode at work. He had 6 months of continuous and increasing pain with work, but he was a self-employed landscape designer, which required him to work every day in order to pay his bills. He had pain-limited overhead work, so he wasn't able to work consistently at 120 degrees of elevation or greater. And he showed increasing fatigue over time with his overhead work. So at work, he really had a moderate level of irritability, but the rest of his life was really he functioned at a low level of irritability. His symptoms were pain with overhead work. His signs were decreased glenohumeral joint range of motion, decreased thoracic spine and rib mobility, poor motor control and endurance, especially of his posterior musculature, scapular dyskinesis, which was aided by a scapular assistance test, impaired function, really increased night pain, a VAS score at rest of 3, but at work at 8 to 9. His PEN score was 92 and his SANE score was 35. His pain really was generalized throughout the shoulder, but primarily anterior type shoulder pain. So the question was, where do we start with this gentleman? So the first and most important area was the acknowledgement of his need to work, his work issues, and to try to come up with some choices he could make to intersperse really consultation on landscape design with activities where he needed to work overhead, and really to plan his week out ahead of time so that he could manage his pain both at work and at home. And he could do some of this independently. We wanted to improve his available range of motion with him doing a foam roll and flexibility extensibility program at home, having him come in for treatment specifically to address some of his impairments in his range of motion and capsular mobility, and to improve his available range of motion. Then we progressed with motor control activities in the clinic and gave him some cues to know when he was really functioning at the highest level and still using correct motor patterns, which decreased his overall pain. His prognosis and progress. We were treating him 1 time a week. He had a huge commitment to his home exercise program and was very communicative when he needed help progressing his program. We gave him some visual and tactile cues with the program that we were able to then transfer to his landscape activities. His symptoms quickly became manageable, but they didn't really resolve until he was able to have an extended period of rest in his sort of down season. He periodically still checks in for increased intervention or change in his home exercise program. So for him, it was careful attention to detail and really giving him and equipping him with the tools that he needed to manage his shoulder pain, really regardless of the ultimate pathology. And so I feel like the combination of a really very specific examination combined with levels of irritability can really help us tailor and progress our patients so they can get back to full goal activities. Thank you.